everybody, how's it going today? Yes, happy Friday, right at the end too. My goodness. Aaron, Nicole, Kate, Alyssa, Allison, Isabel. Got my usual early crew. I love it. Fantastic. Kylie, how's it going? I posted up the last two PowerPoints, so we should be good to go from a materials standpoint, so you can see those. Got my immunizations and the tox one. I think I'll have enough time. I don't need to cut anything out, which would be nice. I can tell you're just so eager to learn all these meds. There are some good meds. Hey, Abby. I was trying to find a video that I'd seen recently that explains how the COVID vaccine works. This guy, I'm gonna post up in the chat here. If you have a few moments, I'd recommend checking it out because it's pretty funny. Hey, Peter. Hey, Nicole. Start here in just a minute or two. I was expecting maybe like 10 people to show up Friday at 2:30. Oh. Can't imagine too many people want to come in, but hopefully Professor Gerke's class was enlightening. But all right, it is 2:30. I'm gonna start recording, and yeah, so let's go ahead and get started. We were covering our medications for specifically like code type of situations. There, we talked about rapid sequence intubation, all that fun stuff. Up next, we'll continue our ACLS meds, and then we have kind of a smattering of different topics we'll kind of touch on from the emergency standpoint. Hey, Shelby. Someone had a question here. They said, so both lidocaine and amiodarone need loading dose and continuous drip. That is true. Both of those are meds that sort of benefit from, amio in particular. Lidocaine doesn't have a particularly long half-life, but because it does get cleared out so quickly, you do want to be able to titrate that, and that's why they do the continuous infusion for the lidocaine. For the amiodarone, we're getting them at that steady state, so that way we hit them with the bolus dose up front to load them and get them at their steady state quick. And then you follow up with that continuous infusion just to maintain that consistent level. You don't want it to really, vacillate too much from there if it's being effective in preventing, the ventricles from going into an arrhythmia. So that's what you do for both of those. All right. So next up, switch over to the slides. There'll be two separate orders. Yes, typically anytime you're doing a bolus and then a continuous infusion, those are technically written as two separate orders. So as an example, you could say like amiodarone 300 milligrams IV over 30 minutes, and then you would say, amio, I can't remember the dose off the top of my head. I haven't done it in a while. But how many ever milligrams per hour that you want, and then we'll figure from the pharmacy side, we'll figure out, how much volume that is and all of that and concentrations and things. Sometimes you guys will make decisions on that stuff, like in terms of clicking off which concentration of a drug you want, but for the most part, that stuff's fixed and taken care of on the pharmacy side of things. But yeah, 2 separate orders if you wanted like, as needed doses on top of that. So for instance, too, you'll see this with like sedation meds. So if someone was on like a fentanyl drip for sedation purposes, and you may do this like for fentanyl and Versed, this would be, again, separate orders. But you have them on the continuous drip. So you're like, fentanyl 0.5 or 1 mics per kilo per hour running, and then you could have an as needed bolus order that would be good for like if patients experiencing agitation or something like that, or you can put whatever specific needs are for that. So then you have a separate order as fentanyl 1 mic per kilo, Q 2 hours as needed for agitation or something like that would be what you would do that for. And again, it's hard. If the patient's intubated, they oftentimes are not going to be able to tell you they're in pain, and especially if they're being sedated. So frequently you're using like other scales and things like that to kind of tell you, okay, well, if the patient's doing these things, then they should probably need more drug in order to help them become more sedate, basically. Anywho. So next up, the next ACLS med we'll talk about here is sodium bicarb. This is a favorite of mine because we use it for all kinds of different toxicologic purposes. We will do this a lot for, or in order to try and alkalize either the blood or the urine. We'll do this for tox all the time. So for instance, you have like an aspirin overdose. Alkalizing the urine helps you to clear it much more quickly from the kidneys. Or if you have something like a TCA overdose, like an amitriptyline or something, this is really good to help alkalize the blood in order to help out with things like protein binding and whatnot. So not to get too big into the weeds there. What we do this for most frequently, though, is going to be hyperkalemia or for correction of acidosis. Once a person is in cardiac arrest, they're not really going to be breathing that well on their own. And so your body is going to be oxygen deprived. You're going to be switching from aerobic to anaerobic metabolism, and you're going to be producing a lot of acid. So it's not uncommon for these patients to become acidotic if they're not perfusing the tissues very well with nice, oxygenated blood. So in those cases there, we can use sodium bicarb to help out with that. So I'll talk about hyperkalemia in more detail a little bit later on, but yeah, so lots of purposes for this. You'll see it used for all kinds of things. The dose we typically use is 1 milliequivalent per kilo. And you'll see this there. And again, I'm not going to ask you about the dose specifically, but you're going to see there's actually 2 different varieties that you're going to run into most frequently in the code card. There's a 4.2% and an 8.4%. Those numbers seem kind of arbitrary, but if you actually look at the concentration of how many milliequivalents it is, it's 0.5 and 1 milliequivalent, respectively. And so that's important because, again, they can get screwed up. And the 8.4%, the one that is 1 milliequivalent per ml, comes in a nice big 50 ml syringe. That's 50 milliequivalents of bicarb. That's a pretty decent bolus for if someone says give an amp of bicarb. That's generally what they're referring to. But again, if you get that mixed up and have the smaller or the less concentrated form, that's the one we use for infants. And that is one less concentrated, but also only comes like in a 10 ml syringe. So you're getting a lot less bicarb. So that's why you want to be specific and saying, okay, well, you want to amp a bicarb. Like, what does that mean? Like, do you want which concentration? How big of a dose do you actually want, etc. Right? I'm going to close my Outlook so I'm not getting alerts and things. So there's that. The in terms of side effects, there's not a ton, but you can see tetany. I've never actually run into it, but you can see it rarely due to pushing large doses quickly due to this kind of transient hypocalcemia that you can end up seeing there. But yeah, otherwise a pretty good drug. Like I said, I use it for aspirin overdoses, TCA overdoses, all kinds of things there. Occasionally you may see sodium bicarb being added in to fluids, like if they had a patient who was getting, who was like maybe acidotic and you're trying to correct that more slowly, you could put it into their maintenance fluids. But you always want to make sure that you're maintaining everything, keeping it isotonic. Okay, so if you ever see, for instance, like half normal saline with 75 milliequivalents per liter of bicarb, that's still isotonic, right? Because if you recall, normal saline has 154 milliequivalents per liter of sodium. So if I use half normal saline, then that's 74? About 75 almost, or 76, I should say. So if you take that 77, I don't know why I can't do math right now. 156. Anyway, 78. My goodness, math is hard today. But anyway, so around that number of milliequivalents. So by adding in 75 milliequivalents of sodium bicarb, you now add that extra sodium in, so now it's isotonic. So you may see that occasionally when doing like bicarb drips and things like that. Or in the case if we're doing like a bicarb drip for a poisoning, we'll do D5, but then add in 150 milliequivalents of sodium bicarb, and that will then give us the ability to keep that isotonic as well, because then it's still 150 milliequivalents of sodium. So again, always try to keep it isotonic. Someone says, which dose of bicarb did you say we use more in the ER? Use the bigger concentration one. So the one that's 1 milliequivalent per ml, that's 50 ml, big syringe. Those are the more common ones you run into. Even if I'm like running a code on a baby, I still use most frequently the larger concentration one, because we can give it in less volume. You just have to be making sure that you're being specific about which one that you're giving there. So let's see. Someone said, Professor Q sent us a link to watch the doctor testify for George Floyd case, and he said he used sodium bicarb and epinephrine. So interesting learning it and seeing it being carried out in real life. That's pretty cool. Yeah, I saw the article where he was testifying. I didn't see what he said specifically, but yeah. So we'll talk about the cardiac arrest algorithm here in just a little bit. But like bicarb and epinephrine, like those are like your some of your go-to ones. Epinephrine you're going to be given every 3 to 5 minutes. Bicarb, obviously if someone was being asphyxiated, they're not breathing, they're going to become acidotic, just like I mentioned. So that bicarb would certainly be useful there. And again, you're typically getting kind of bedside point of care testing done, so you can see what the pH is. You don't necessarily have to get an ABG, but you can do some point of care testing in order to you get a decent idea of what the pH is. And I imagine him rolling in after that period of time was probably pretty acidotic, if I had to imagine. Yeah, but definitely interesting stuff for sure. Still a very sad case. Hard to believe how long ago that was now. It's like this whole past year's been gone by in a flash for sure. But anyway, so as I mentioned, bicarb, you're going to use it quite frequently, especially in a code situation. Calcium is also going to be used here pretty frequently. You're going to find two varieties. You're going to find calcium gluconate and calcium chloride. And I know you guys are probably thinking, like, why is he going over all these concentrations? And like, why do I care about milliequivalents? This stuff does matter. Like, you can make some pretty big mistakes, especially in a code situation where it is hectic to say the least. This is why we do sims for this stuff all the time, because if you're not practiced at it, you can panic. You can get mixed up and make silly mistakes that you otherwise wouldn't if you were in a more controlled environment. Anyway, other indications here for calcium would be hypocalcemia. That makes good sense. Hyperkalemia. We'll see how we're going to use that. It helps to stabilize the myocardium. And also for massive transfusion. So kind of similar to what I talked about previously with dialysis, how they use a citrate anticoagulant to keep blood from coagulating when it's in the dialysis circuit, and how that can cause hypocalcemia. Giving massive transfusions of blood, that blood has to be kept from coagulating as well, and so citrate can be used there additionally. So if you were, in a trauma center and having to do a mass transfusion of, several units of blood, we will frequently give calcium along with that in order to replace what might be getting bound up by that citrate there. So a very common, set of orders you'd be seeing there in more of the trauma sort of setting. Now, calcium gluconate and calcium chloride, the calcium is exactly the same. It's just a salt form that's different. And so two of the big changes you're going to see here is that, they both come in a 1 gram vial. They both come of the respective salts. They both come in a 10 ml vial. I'm going to show you what the picture looks like here in a second. But the amount of calcium in there is actually quite different. And so the handy sort of ratio that I use to keep this straight is that for every 1 gram of calcium chloride that you have, you would have to give, to get the equivalent amount of calcium, you have to give 3 grams of calcium gluconate. So it's a 3-to-1 ratio of gluconate to chloride to get the same amount of elemental calcium, okay? That's a good number to know in the future, because you might get asked that on rounds and whatnot. With this, you're going to find that typically, and if you look at the max doses, it kind of bears that out as well. With chloride, you get about a 1 gram max dose per single dose, and gluconate's at 3 grams. That kind of makes sense. Calcium chloride we don't like to use for patients who are still conscious, typically, like at least in the ER setting, because it can be really, really harsh on the veins. can certainly cause tissue, if it extravasates, can certainly cause tissue necrosis and damage. So we'd like to use the deepest vein possible, meaning that it's kind of closest to the central access as possible. So being able to, as close to the vena cava as possible there. And if you can do it in a central line, that is always going to be preferred there. If they are like actively coding and they have no pulse, then you can just get the calcium chloride IV, because again, if the patient dies, I'd rather their veins hurt and they live than the alternative. So it allows you to give the drug that much more quickly. Gluconate tends to be easier on the veins, and so if you only had like a peripheral vein, if the patient was, you're doing it for hypocalcemia, calcium gluconate is totally fine. I would default to that most of the time, unless you're in that actual like code sort of situation there. As I mentioned, here's the adverse reactions. The thrombophlebitis probably being the most common thing, more so with the chloride than the gluconate. And again, just to show you how these medical errors can occur, you'll find both of these sitting in a code cart practically next to each other. Notice they're both a 10% solution. Notice that they are both 10 mLs. They both say calcium on them. They look near identical. And if you didn't know the difference, though, you could easily separate or get these two mixed up. And so when someone says something like give an amp of calcium, what do they mean? You need to be specific. And so that's why we like to do what we call closed loop communication. I'm sure you guys have heard this before. But for instance, if I say something to you, I give you an order, you would then repeat that order right back to me and say, okay, so this is what you want. And then I would say yes, or I would clarify if there's some sort of miscommunication. Because again, the time from when the provider says give this med to the time it's pushed into the patient is the fastest you're ever going to see that is probably like in the OR or in the ER sort of setting like this. And so there's really not a lot of time to catch mistakes, and this is why I got to be really specific here. I was asking, are there different indications for calcium chloride versus gluconate, or just both used for hypocalcemia? No specific difference. I mean, they both will separate into their constituent components there. So the calcium does what the calcium does, regardless of which salt you put it in. Other than that, there's not really one specific indication for one over the other. It's more so of an administration sort of concern in terms of like, what kind of IV access do you have for the patient? Trying to think other considerations there as well. How emergently do you need it? Is it something to where drawing up that 3 grams of calcium gluconate is going to be deleterious to the patient as opposed to just using the 1 gram? So those are kind of fringe sort of cases I can think of, but in general, those are the most, either one is going to be fine. There's just, you have to account for the difference in the elemental calcium content. So 3 grams of calcium gluconate is going to be equivalent to 1 gram of calcium chloride. So just kind of keep that straight there. All right. Interestingly enough, if you ever have calcium, kind of a unique case you can use for calcium is actually if you ever have someone who had a hydrofluoric acid exposure. It sounds kind of like an odd tangent to go on. But if you ever want to see one of the worst sort of burns you can ever have from a chemical, hydrofluoric acid is probably it. It is really, really bad stuff when you see it. Why my Outlook is still acting like it's open when I try to close it. Sorry, like alerts. So hydrofluoric acid can be really nasty. It binds up like a lot of different types of electrolytes, and it can be rapidly fatal if not caught and treated early. And when do you run into hydrofluoric acid? It's mostly with things like chrome wheel cleaners. Sometimes like etching, things used for like glass etching is typically hydrofluoric acid. So it's you can find it out there in the wild fairly easily. But you can actually, and so usually it's like a hand exposure that happens, and the patients will just have like the worst pain in their life they're experiencing, even though the hand looks fine, even these kind of minor exposures. So what we actually can do is we can take calcium chloride or even Tums, we can crush them up and put them in Vaseline, and then we'll place that on in a glove, like a latex glove, and then put that on the patient's hands. That way they have that calcium there that can bind up the fluoride, hydrofluoric acid, and then neutralize it. So kind of a unique little case there of using calcium for a different indication. Okay, anyway, so looking at naloxone. So we know about naloxone. We know this is our opioid antagonist that is going to be used here to help reverse opioid ingestions, right, and opioid exposures there. So we're antagonizing the opioid receptor. We're going to reverse that CNS and the respiratory depression. Keep in mind, you can't have too much of a good thing, and you can cause these patients to go into very severe withdrawals. And this stuff does kick in within seconds. So, I mean, you can have a patient going from needing to be intubated, and then 10 seconds later, they're up screaming, yelling at you about how you wasted their money because you reversed their heroin or whatever it happens to be, right? So, sometimes we will try to give smaller doses to see if we can at least get them to start breathing. This is where it's handy to use things like end-tidal CO2 monitors, because they can kind of tell you how well they are at getting rid of that CO2. If it starts to, creep up into like, the 50s, 60s, 70s, like, they're not expelling enough CO2 on their own. And so you can give them more Narcan to try to help reverse that. So, if it's a code type of situation, you typically don't really care. You're just going to blast them with it. So, 2 to 4 milligrams is typically a dose you're going to see for most patients there. Again, if they're opioid tolerant, which you might not know at the time, just be careful by giving too much. Because again, once they start to wake up and you start to reverse all that, like stuff like their GI tract is going to wake up too. They can have a lot of diarrhea, vomiting. All of a sudden, you can have a very kind of messy scene that you're working with there, unfortunately. So, other things. So, dextrose we can give. What's our indication for dextrose? Pretty easy for hypoglycemia, right? So, if the blood sugar comes back low, we can go ahead and give this. And so, typically, we're giving between 0.5 and 1 gram per kilo, typically capping out around 25 grams, maybe sometimes 50 in some cases there, depending on severity. So this one is you're going to find several different concentrations. Dextrose is another one that at high concentrations, like D50, when you hear a D50, that's the one you typically find in the code cart, and that can be pretty harsh on the veins. But still, if the patient's coding, then I don't really care about the veins so much as I do about them being alive. So giving the D50 is acceptable in adults in those sorts of situations. Using D25 and using D10 are going to be easier on the veins. Typically for infants, we'll default to D10. D25 for children and adolescents is a pretty good rule of thumb there. However, if I'm not worried about the fluid and I don't need to correct it like right this second, then using D10 is pretty reasonable in a lot of cases there. So especially like, if you have a diabetic kid who comes in, and their blood sugar is like 50 and they're feeling a little woozy, like, I can give them D10. I don't have to slam them with a D50, right? Ideally, you like to give it orally if you could, but maybe not able to for whatever reason. But yeah, irritation of the veins, hyperglycemia obviously would be another potential risk there, but that's something you'd probably take at that point. So getting into the actual algorithm here. So I think there's a 2020 update, but I checked it out and there's actually not any differences in terms of medication. So that's basically what I'm gonna be focusing on here. Obviously, and I'll just kind of go through. I'm trying to make it bigger so you guys can see a little easier there on your screen, hopefully. So anyway, so let's say we have someone who is in cardiac arrest. Basically, you're going to go through and see, okay, are they in a shockable rhythm? Are they in asystole PEA, or are they in VFib, VTAC? And we can go ahead and shock them. Note here that if you can shock them, that's a good idea. Go ahead and do that. And then meanwhile, while you're doing the defibrillations, you will be giving epinephrine every 3 to 5 minutes. And again, if no one is keeping track, it's very easy to lose this and either give it too frequently or give it too infrequently. This is why having like a timekeeper, even though it sounds silly to have like a whole person just keeping time, like that can be super useful there. So either like your nurse is doing documentation or somebody. I like to keep my own timer if I'm at a code, just so I can say, hey, it's been 3 minutes since the last epi. Do you want another one? And typically they'll say yes, and then you go ahead and give the next dose. So anyway, so that's really going to be the biggest thing here. Typically, if they're not responsive to defibrillation, like electric defibrillation, you can try to do go the chemical route, and this is where amiodarone is going to come into play here. So if they're in VFib, VTAC, and they're not responding to shocks, then we go ahead and give them the amiodarone and try that out to see if it's going to work. If you couldn't do amio, then lidocaine would be sort of a backup there, but typically most people default to amiodarone nowadays. Cassette saying having to chart all this in real time as a scribe was a nightmare, especially if it's an hour-long code. Yeah, which, I mean, I don't know how many hour-long codes I've been to outside of pediatrics. I think they tend to run those a lot longer, especially when the parents are around, just so they can see you kind of did everything. I saw a lot of adult ones go much shorter because, you kind of know after, 5-10 minutes if it's not going to be a very good outcome for that patient there. But yeah, it's kind of interesting. Just a side note there, it's pretty wild. I don't know if anyone's ever, I'm sure many of you have been to a code or participated. I'll remember one time when I was, I can't remember if I was a student. I think I was in fellowships. I was a full pharmacist by then. But I remember we had at our it's called the ECC, so it's like extended critical care or something like that in the ER, and we had 4 beds basically, where like the sickest of the the sickest of the sick patients would go there. Oh yeah, they go in and out. Yeah, I could certainly see that. So I remember we had basically 2 codes running at the same time. Let me finish the story. I'll talk to Marley's point. So anyway, so we had two patients that were coding, and basically we had enough people there to help manage the medications, but we were having a hard time because we didn't have enough people to give compressions, and so like everyone's getting kind of tired out, and so eventually they looked over at me and they said, "Okay, you're up next for compressions," and I go, "What? Excuse me? What? Sorry." And they said, "No, you're up next in 2 minutes." So basically, I had to get up there, and I was actually doing compressions on this patient, which was the first time I'd ever done that, which is a pretty wild sort of scenario. But then I remember the doc finally said, "Okay, we're gonna go ahead and call it." So I stopped doing CPR. But then it was the patient's wife had come in at that point, and she was just looking at me like, "What are you doing? Keep going." And I'm looking at the doc, being like, "You want me to stop, right?" And she's like, "Yeah." It's a real awkward sort of situation, but kind of a formative moment there. So sometimes you may be the ones doing compressions, even though you may not think about it. There you go, Shelby. Yeah, I mean, you gotta pull everyone in you can. Environmental services, dietitians, maybe, who knows, So amio is most commonly going to be given in that situation there. There's not really a case where you're going to be giving it, because if they're in asystole, they don't really have a rhythm for you to actually fix, right? So amio is not really going to be doing much for you. So in those cases, yes, you can do that there. Certainly, we may be giving amio for other purposes, but this is specifically in cardiac arrest there for sure. Let's see. Yeah, very good abdominal. It's like crazy how tired you can get even after doing just a couple of rounds of that for sure. It's pretty wild stuff. Anyway, so otherwise, if they're in PEA or asystole, then you're just doing epinephrine every 3 to 5 minutes. Now, you may be given other things at the same time here. So, for instance, if you get you get the point of care test done and it comes back and they're acidotic, then you can make the decision. Okay, let's do bicarb. If you get the glucose back and it comes back and it's 30, okay, you can give the dextrose. You may be doing other things at the same time here, but really in terms of like treating the actual cardiac arrest, like epi's the big thing every 3 to 5 minutes. So it's pretty straightforward there. And again, think about the H's and T's. This is something that, again, they make these mnemonics because when you're in the middle of a hectic situation, you have to, be able to kind of think through these things systematically to make sure you've addressed everything that you possibly can. So, for instance, things that I can think of right off the bat that we can help with medications could be hypovolemia. So, do we need to get more fluids on board? Do we need to give them a bolus of NS, for instance? From an acidosis standpoint, we can give bicarb. From a hyperkalemia standpoint, we can give them some medications I'll talk about in just a little bit. I have a whole section on hyperkalemia. Hypokalemia, pretty simply, give them potassium and fix that. And other things like toxins, so you can see, like, is there any thought that there was like a drug overdose? Because in some cases, we can try to do things like Narcan. Or, if they had, for instance, if it was like a TCA overdose, like giving sodium bicarb can work for that as well. If it's a thrombosis, do we need to give them a clot buster? Do we need to give them something like TPA to treat that? So you kind of go through those and think of all the things that could be happening here. It could be the reason why the patient is coding, and try to reverse those if possible. And otherwise, if not, they can't come up with anything else, then you might just call it, Okay, so going to the algorithm here, we're looking at adults with tachycardia. Basically, here is where you can start to consider things like, okay, where are we at in terms of, do I think this is more of a ventricular arrhythmia? Do I think this is more of an atrial originating arrhythmia? And that can give you some clues. So if you're in PSVT, really the biggest thing you're going to be giving here is going to be adenosine. Adenosine is going to be the first stop there. Typically, if that's not working, and then you're going to be considering things like amiodarone as like sort of a backup. So typically with adenosine, give you 6 milligrams. That doesn't work, give you 12 milligrams. You might try a third dose in some cases. Otherwise, you might want to get the amio available, and then you can go ahead and treat that. Other things you can consider doing too include things like calcium channel blockers, so particularly like your non-DHP, so like verapamil and diltiazem. Beta blockers could be potentially useful, things like labetalol, metoprolol, things you have IV options available to. And then you can also consider things like amiodarone as well. So I'll give you a really good example of a kid who came in with PSVT. I think they were Here they're less than 1 year old, but if they were, it was pretty close to 1 year. And PSVT, and again, we were trying a lot of non-pharmacologic means of getting them to break that, which wasn't working. So we ended up doing 3 rounds of adenosine. That was ineffective. So we tried getting out the non-DHP. So I think we went with diltiazem at the time. That was not working. And again, you're getting your consultants on board too. So we had cardiology there, we had ICU people there, so we had a lot of good minds kind of providing support there in terms of what decisions we made. So we did the non-DHP, so we tried the diltiazem to try to get the rate under control, but that really wasn't working either. Then we tried amio, several doses of that still wasn't really working, and then at a point we ended up having to put the patient on ECMO. So that could be kind of your last option if that's available wherever you're working. But so you kind of go through the list of things to see, okay, how can we slow this rhythm down? In case of ventricular arrhythmias, really amio is going to be your first line therapy in most cases there. But if it's more atrial, then you can think about things that slows down that nodal conduction. So beta blockers, non-DHPs, that sort of thing. Okay. That makes sense. For bradycardia, really, again, if you can try to find the reason why they're bradycardic, that can be really helpful in terms of deciding what you're going to do. But generally, first line is going to be atropine, right? And this is from a medication standpoint, right? So you could have things like transcutaneous pacing, but generally atropine will be the first thing you're going to try here. And then you can try other things that are going to be stimulatory on the heart, which I'll be talking about here in just a little bit. So things like dopamine infusions or epinephrine infusions can also be useful here as well, especially if they're hypotensive. Those two can be really good to kind of get the heart in action, and we'll kind of clamp down on the vessels as well. But I'll talk about our vasopressors here in just a few moments. Again, if I'm glossing over anything or I say something that doesn't make sense, just let me know and I'll go back to it for sure. So with peds can be a really big challenge. After you've done it for a little while, it kind of becomes second nature. So it's not really that scary. It's just, it can sometimes be tough when, like the parents are in the room and their kids coding and things like that. But generally we always try to have, again, things systematized as much as possible, because if you do it the same way every time, you're less likely to omit things or screw things up. So we typically have like code sheets that are designed to help with specific patient weights. Again, this can be a challenge because sometimes parents may not know the most up-to-date weight for the child. Sometimes you will have scales built into the beds. That can be useful if they're rated for peds. And then, if all, in some cases you may be using tapes that actually can, I think I have a picture here in just a second. Yeah, so here's an example of the Brazel-Luton tape. This one actually does it based on the height of the child. And so basically whatever, you put the right end at the head and then right to head, as they say, and then you see what area they fall into. So this kid here would probably be a yellow. And so then you say, okay, they're likely 12 to 14 kilos. And then they dose some medications based off of that. Obviously, there's some limitations to that, especially if you have kids who are of, lesser or higher body weights for their height. You can find issues if you can't get an accurate height on the kid, especially if they have contractures and things like that. So that can be a bit of a challenge. But basically, having a nice code sheet available to you that already has like the doses and the volumes already set up for you based on the weight can keep things very easy, or easier, I should say. That way you don't have to do calculations in the middle of a code. Because again, doing even simple math can be really, really difficult if you're in that code situation where someone's like, okay, where's that med at? Get it ready. And you're sitting there trying to figure out, okay, well, if this comes as a 0.5 milligram per ml concentration and I need 0.3 milligrams, and how much volume do I need? You don't even want to mess with that, right? It can be tough even if you're not in the code situation. So generally speaking, if the patient is between weights, just round up. It's okay. If they're coding, give them a little bit extra meds. That's probably going to be on the safer end of things, if anything. Yeah, so someone's asking, can I repeat the preferred order of meds for tachycardia? So first you got to figure out, why are they tachycardic? So is it more originating in the atria, or is this more of a ventricular sort of problem, right? If it's a ventricular problem, in terms of meds, you're probably going to be considering mostly just amiodarone for the most part, right? Because again, that's going to be more beneficial for treating those ventricular arrhythmias. Sometimes you might use things like procainamide. That's going to be more in a specific sort of situation there. Most of the ER providers are not going to be ordering that. It'll probably be the specialists doing that. But on the other hand, if it's more originating above the ventricles, then what we can do is try to either correct the rhythm with something like adenosine, or we can try to slow the rhythm down, so that way the ventricles aren't trying to work so hard, right? Because again, I don't need the atria to really be working that well to get good perfusion. I just need the ventricles working. So in the case where something like adenosine is not working to convert them into normal sinus, then you could use something like a beta blocker or a non-dihydropyridine calcium channel blocker typically. And if that's still not working, then you can try something like amio to try to, again, do the chemical cardioversion there and put them back in a normal sinus. Again, the goal is to make sure those ventricles are still pumping with some efficiency and they're not going to tire out. So that's kind of the big thing there. So hopefully that makes sense. Here's an example of what that code sheet would look like. So you can see here, this is nice because you can just plug in the patient's weight, or you can have it pre-printed potentially, and it'll tell you how much to give in terms of electricity for defibrillation. It'll tell you how much volume to administer of the kind of the standard concentrations of these medications here. So again, it keeps it straight, so that way you're not trying to do math in the middle of trying in the middle of a code sort of situation there, right? Here's some the intubation meds. So for instance, this was from our ER, and this is kind of our standard. So we always use etomidate and succinylcholine, and then if we need the pre-meds, we do atropine or lidocaine as needed there, right? For some places, they would do what they call a controlled intubation. There's like our ICU providers, and they like to use rocuronium as their preferred paralytic, and then sometimes they use fentanyl Versed, sometimes they use propofol. It really just depends on the provider from that standpoint, so. I'm trying to think, did I miss anything there? I don't think so. Yeah, so the Brozoluten tape, okay, but they don't give you the drug volumes, and so that can be kind of tough, especially if you're not used to doing those kind of calculations pretty quickly. So as I mentioned, other tips to kind of help out with safe resuscitative experiences to make sure that you're calling back things with the provider. So this could be with anyone, any two-way communication happening. You want to make sure that things are being called back and forth to make sure that everyone is understood. Be really precise in your language, because saying give an amp of calcium doesn't really tell me a whole lot. Okay, so we don't even really use a lot of ampules anymore, so even that's inaccurate. So if someone says give an amp of calcium, I'll usually say, so you would like 1 gram of calcium chloride, correct? And then they can either correct me and no, I make calcium gluconate, right? That's the big difference there. Always use your units. I've seen cases where whole bottles of nitroglycerin have been infused way too quickly into a patient because the units were incorrect. So someone will say start the dopamine at 5. 5 what? 5 ducks? Like, I don't know what you're talking about. Do you want mics per kilo per minute? Do you want milligrams per kilogram per hour? These can all be very different things, right? There are some standards out there, but you can't assume that everyone's on the same standard you are, okay? That's why you want to always make sure you're using your units and being very precise in your language. Okay, so any questions on that? If so, let me know. Continuing on, we have our chronotropes, inotropes, and vasopressors. Oh my. So what are chronotropes? Chronotropes are basically anything that's going to be increasing the speed of the heart's contractions, right? So we're going to get a faster heartbeat, more beats per minute. We're going to see our inotropes are going to help out with our contractility. So this is good for like patients with CHF. You need a stronger squeeze on the heart. And then our vasopressors are anything that's increasing peripheral vascular resistance by squeezing down those blood vessels to increase the blood pressure. I make this distinction here because you're going to find some of these drugs may fulfill different roles within that. Some of them may be better at one versus the other. So I like to just delineate that. So if I say something has a positive inotrope, you'll know what I'm talking about. I'm increasing the contractility of the heart. This is a negative chronotrope. Beta blockers slow down the heart rate, so that would be a negative chronotrope, right? Chronotrope, one of my favorite RPGs of all time, right? Anyway, so dopamine. Dopamine is a pretty common med you're going to be seeing in the ER, ICU sort of setting here. Basically, this acts just like our own endogenous dopamine that we have here. It's also serving as sort of a metabolic precursor. It gets converted over into things like epi, norepi, and so you'll see sort of a general trend in terms of how all these meds are going to be working together here. Dopamine is kind of interesting because it has sort of a dose-dependent effect. So depending on what dose you're giving, you may get a little bit different effects here. And sort of kind of blend together, when you get kind of close to the borders here. Usually 1 to 5 mics per kilo per minute of dopamine. Again, see, I'm being specific with my units. Because if I did 1 to 5 mics per kilo per hour, that would be a whole lot less dopamine. That you'd end up maybe 1/60th of the dose that you want, right? This is generally good because it will act on dopamine receptors in the kidneys that actually cause increased renal blood flow and urine output. That's okay, but we don't use it a lot for that purpose in the ER setting. We're usually giving higher doses because when you get up into the mid-range between 5 and 10 mics per kilo per minute, it's going to be predominantly acting on your beta-1 receptors. So this is going to be both a positive inotrope and a positive chronotrope. So you're going to get an increased heart rate, you're going to get more contractility, and ultimately more cardiac output. Okay. When you start to get up higher than that, up to 10 mics per kilo per minute and up, then you're going to get more alpha activation, so alpha-1 receptor activation. So now on top of that increased contractility and heart rate, now you're going to get more vasoconstriction. So you can see early, in the mid-range, it's working more as a, inotrope, a chronotrope, but at the higher doses is where you're going to get the vasopressor effects, right? I would expect you to know sort of like, not the numbers necessarily. I'm not going to say the patient's on 8 mics per kilo per minute, what effects are you expecting to see, but I would expect you to know kind of the low, medium, and the high effects. So if I'm giving medium dose dopamine, what kind of effects am I going to see versus high dose? Okay. So that's about as granular as I want to get with that. So anyway, the high dose, you're going to get the alpha constriction. So this is good if a patient is, say, coming in for a CHF exacerbation and they are, the cardiac output is the main issue, then putting them on, medium dose dopamine may be a good option. That'll help to increase cardiac output, help with perfusion. Whereas if I have someone who is like septic and they're really hypotensive, then I'd be using higher dose dopamine in order to get that pressure back up, just as an example. And again, with all of these, you may see some of these running concurrently in order just to get even greater effect out of it. It's not like they get a ton of additional synergy, but in some cases you will see some additional benefit by using multiple of these concurrently. I'll give you an example of that later. So, adverse effects. These might be kind of consistent amongst some of these, as we'll see here. So you'll see some parallels with all the vasopressors here coming up. So first off, make sure the patient's not hypovolemic, because if the patient is hypotensive and you're trying to increase that squeeze, if there's nothing in the hose to fill it up, there's not enough water, you're not really going to be doing yourself much good. So you always want to make sure that the patient is not hypovolemic. Most of the time by the time you're giving dopamine, you've probably already given some fluids, but it's just a consideration to make there to make sure the patient's well tanked up from that standpoint. The stimulation on the heart can lead to tachyarrhythmias. Who would have guessed, right? So things like, palpitations, sinus tach, PVCs can be seen. Rarely could you develop, full-blown, dysrhythmia. For sure, you can do that because, again, you're kind of increasing the activity on the heart, increasing that stimulation. Eventually, you could develop, tachyarrhythmia for sure. Typically, as your dose goes higher and higher, and you typically don't want to use more than 20 mics per kilo per minute, you can start to see peripheral vasoconstriction of things like splanchnic vasoconstriction, which can lead to tissue not getting enough oxygen, right? So things like, seeing mesenteric ischemia is possible. You may start to have lesser perfusion of the kidneys, which can lead to kidney injury. Cases of things like gangrene have happened before, in the distal limbs because of all this vasoconstriction. Okay, just like we talked about, we don't want to put epi in the toes or the fingers. The same thing here can happen, basically, if they're on really high doses. So that in the higher doses, you don't really get much more benefit, but you do see more like arrhythmias and things like that. The alpha stimulation here is kind of what I was referring to. Chest pain can be seen, cold extremities, etc. This is another set of drugs too. You want to be careful with extravasation. If it goes out into the local tissues, you can see injury and necrosis that can occur there. This is actually treated with a drug called phenylephrine, which is a specific alpha blocker that you could actually infuse into the surrounding tissue, and that would help out with relieving some of that vasoconstriction. So that could be one thing you could do from that standpoint there. And you'll see this is pretty consistent with a lot of the vasoconstrictors we'll talk about here. Okay, up next we have epinephrine, which we've talked about previously in terms of its use for ACLS purposes, and we've talked about it before for things like anaphylaxis. There's lots of uses for this, so we can use it topically, in some cases there, inhaled, which you will oftentimes do for things like croup. It's probably one of the more common things you'll see there is inhaled. They call it rack epi sometimes. Rack epi just stands for racemic epinephrine, just referring to the fact that it's not one enantiomer or the other, it's just racemic mixture. I don't know why that was the nomenclature, but that's what they went with. So you'll see that inhaled occasionally for croup. And then oftentimes we may see intramuscular administration for things like For instance, anaphylaxis like an EpiPen, right? People can carry that with them and give themselves immediate intramuscular epinephrine there. And actually, you will common to see accidental injections. So certainly, I'd have a lot of calls to the poison center, people who accidentally jab their finger with epinephrine. That would oftentimes lead to it becoming very white and blanched because you're constricting all those vessels. And in some cases, we could keep them at home. They would use things like hot compresses in order to try to expedite the absorption of the epi. So that way it would kind of wear off on the finger. In some cases, though, we did have to send them in order to get some IV, or not IV phentolamine, but sub-Q phentolamine into the finger just to make sure that it wasn't going to cause any permanent nerve damage or things like that. So kind of interesting to see those accidental exposures. Let's see here. Someone like, can you go over the bradycardic drug regimen? Yeah, it's pretty straightforward. You give atropine. If atropine's not working, then you can consider things like dopamine and then epinephrine. Those are pretty much it. I mean, you can do other things like transcutaneous pacing and whatnot, but from a drug standpoint, that's kind of the order that you would go in. And it wouldn't matter, dopamine or epi, either one could certainly work there. Sure. Right. So anyway, when we're using IV epinephrine as a vasopressor, you're going to find here that it has pretty balanced effects between both beta activation and then alpha activation as well. So beta 1 and alpha 1 activity here. So if you had a patient with both bradycardic and hypotensive, then this might be a good option there because you're going to kind of get both of those being boosted up, as opposed to maybe, for instance, someone is just coming in bradycardic, then utilizing maybe medium dose dopamine might be a better option there, for instance, right? So having an idea of, if I gave you a set of vital signs, being able to pick out, okay, what would be my best option for this type of patient, right? And it's not like what is a correct option, because there could be multiples. What's the best option? That's how we give ourselves lots of leeway on our test, as we always say. You said, well, this drug could work. I said it could, but it's not the best option. And that's what I asked. Anyway, remember which receptors are causing those adverse effects. So a lot of like the hypoperfusion is due to the alpha-1 activation and vasoconstriction. The dysrhythmias and things like that are going to be related to the beta-1 activation, right? So kind of be aware of where those the effects are coming from, because we're seeing here in a little bit we're going to have pure alpha agonist. We'll have a pure beta agonist. So it's important to kind of keep that delineation in your mind there. So similar, and again, it's easy to get this confused, but dopamine and dobutamine are frequently confused with one another. This one is going to be just a beta-1 agonist, right? So this is purely going to be helping out with the inotropic effects here and helping out with cardiac output, okay? So it's helping out with contractility. You may see some increase in heart rate, but really the contractility is the biggest thing. This is why we like to use it for decompensated CHF, in order to get the heart kind of kicking a little harder, in order to get that blood out and working. The biggest things you're going to see here is mainly going to be things like PVCs, tachycardia. You can see ventricular tachycardia in some rare cases there. Just a matter of how much you're kind of overstimulating that heart. And then certainly because O2 demand is going up in the heart, you may see angina in those that are susceptible. So that's really the one big role here. So if you had a test question and someone's coming in, heart rate's pretty marginal, their EF is low on echo at the bedside, and you're wondering what you can do as a positive inotrope, like dobutamine is the best option there, right? Another thing you may use, and I don't use this too frequently, I see it very rarely in the cardiac ICU, but you may also see this if you needed to do sort of a chemical stress test. It's more of a provocative testing, right, to see how if a patient has any kind of blockages or angina, things like that. And so isoproterenol could also be used as a pure 1 beta agonist, but 9 times out of 10 in the hospital setting, I see dobutamine being used. So this is more of a special case. Next, I have Milrinose. This one's interesting because it works as both an inotrope but also a vasodilator. And it actually does this by blocking PDE3, right? I know we were just talking about PDE5 recently. We were talking about erectile dysfunction and also affecting the lungs with pulmonary hypertension. This is going to be phosphodiesterase 3, and this is specifically working on breaking down cyclic AMP in the heart and also some effects on the blood vessels as well. So by inhibiting this PDE3, we get more cyclic AMP, and that causes the heart to pump stronger, right? So it's going to get positive inotropic effects. And then also will relax some of the smooth muscle and the vasculature, so you get the blood pressure coming down. So this is good if you have a patient who's coming in for decompensated CHF, but they're still really hypertensive. So they're not really perfusing that well because the blood vessels are clamped down and their heart's not really got a whole lot of cardiac output. So this is a good option in that case there. There are some risks for increased mortality in CHF patients if used chronically. So this is why you kind of use this to kind of get them compensated. You know, put them on the Lasix drip, all of that, get the fluid off of them, help to get them kind of back to baseline, and then you would get rid of this, right? Because of that risk for arrhythmias seen with that. And then obviously hypotension can be another sort of side effect there. So if I said, you know, decompensated CHF patient and they were hypotensive, then this would not be a good option. But if they're hypertensive, then it could be a good option, right? So again, being able to pick out which scenarios would be better for which drugs is going to be important for this section here. Next is Norepi. It's one of my favorites to use for hypotensive patients, especially due to like tox stuff. We usually prefer this one. It had a really bad rap. I remember when I was in school, it always was called Leave 'em Dead instead of Levofed, because if you were putting a patient on Norepi, it pretty much meant that that was your last line of last drug you were using there, and then if you had nothing else after that, the patient was going to die, right? So leave them dead. That's not the case so much anymore. I see a lot of people now preferring this. I think for a long time people just went with dopamine as their kind of first line vasopressor. Nowadays I see a lot more Norepi as a go-to. So again, that may change over time. Who knows? Things probably go in cycles there. But this is the exact same as the endogenous norepinephrine your sympathetic nervous system releases. The reason why we like this, especially with like, certain toxin-related hypotension, is because it works more strongly on alpha constriction than it does on the heart necessarily, right? So if I have someone who had overdosed on, say for instance, like, calcium channel blocker, like a DHP, amlodipine or something, I want to give them a vasopressor. Well, the heart's not the problem, because I know that, the amlodipine doesn't really do a whole lot to the heart specifically. It's really the blood vessels that are wide open. I can use this to help kind of clamp down on those and then leave the heart alone. So I'm not aggravating it as much. So I'm not worried about, things like, dysrhythmias on top of treating that overdose. So I see a lot of people like this for sepsis and all kinds of other conditions. Anytime the patient's hypotensive, this is a pretty good one to go with in a lot of cases there. Someone said, is medium dose dopamine or dobutamine better for CHF, or would they work both just fine? So if you just need the contractility component of it and you had a CHF patient, I would see a lot more people probably err on the side of using dobutamine. However, if someone is like bradycardic, they are, you don't know if they're going to become hypotensive, then dopamine might be a better option there, just because if you need to bump it up to high dose, you could, and just titrate it up and you'd be fine from that standpoint. But you certainly, in decompensated CHF, you may see either. You may see dopamine or dobutamine. But again, if it was someone who is, hypertensive, I might try something like amilrinone. If they're like normotensive, maybe something like dobutamine might be a better option than dopamine. If they're hypotensive, so you kind of think about different situations like that. Although, if it's, I want to try to make the questions pretty clear cut in terms of like which one would be the best or worst option. So I'm going to hopefully not make it, vague enough to where you're like, well, really either of these could be best. I'm going to try to avoid situations like that on the test. You guys may not believe me, but I do try to do that. So does milrinone decrease afterload, helping the heart move blood easier? Yes, it does, right? So because it is working on kicking up your cardiac output, but also causing that vasodilation, it is going to be helping out with the afterload. So that way you're able to one, pump more blood, but then also have an easier time pumping that blood, so it facilitates it moving along that much better. Yes, absolutely right. All right. You can also use something called phenylephrine or neosynephrine. This is what you're going to find in a lot of like over-the-counter cough and cold preparations. If you ever see like Sudafed PE, if you recall, I never recommend that stuff because it doesn't really do a whole lot in terms of oral treatment. But IV phenylephrine is actually really helpful. I see a lot of use in terms of like anesthesiology. Using this like during surgery and whatnot, if you need to keep the pressures just right. So phenylephrine is a pure alpha agonist. When used parenterally, it's going to help you get a lot of really strong vasoconstriction. Now, it doesn't do anything for cardiac output, right? So you wouldn't be expected to see a whole lot like, tachyarrhythmias. But because it is a pure alpha constrictor, we tend to see more issues in terms of like renal hyperperfusion, GI tract hyperperfusion. So you may think, okay, well, the patient's hypotensive, give them this. But honestly, Levophed tends to be a better option in a lot of those cases, where then phenylephrine may be like an add-on drug potentially. So this is usually not first line. It's usually either something like norepinephrine or dopamine, and then maybe epinephrine if you need some additional cardiac output, maybe phenylephrine if you need some additional vasoconstriction. So there it gets a little more hazy in terms of which drugs you're going to add on, right? And then vasopressin is going to take this from a totally different mechanism. So instead of working on alpha receptors or the beta receptors, we're going to be trying to give the patient additional ADH action here, right? So of course, we've seen this used in other cases like for diabetes insipidus. We've seen where instead of using vasopressin specifically, we can use DDAVP. So we talked about that intranasal arginine vasopressin we can get from that standpoint. That's where you see that done more often for things like diabetes insipidus, or if they have like esophageal varices, it can help to clamp down some of those vessels there. But vasopressin is very handy because one, it has some vasoconstrictive properties, but it also has the ability to hold on to more fluid, right? Because it's working down in the kidneys. You're holding on to more of that water, so your volume should go up, intravascular volume, and also you're getting that vasoconstrictive effect. So generally speaking, this is going to be used as sort of an add-on vasopressor. So if I had someone who's on Norepi and I need some additional help in terms of blood pressure, then you could add on something like vasopressin. That could be a good second line agent you'd be adding on there. It used to be that you would give this as like in replacement of one of the first doses of epi during ACLS, but that's been removed from the guidelines for a while now, so I wouldn't really worry too much about that one. And in terms of side effects, really not a whole lot to speak of here. Most of the time these patients are so sick, they're probably going to be intubated in a lot of cases. But you could see things like water intoxication due to the thirst response is going to be pretty strong with this one, since it's ADH basically, right? Someone said, sorry if I'm behind in the algorithm for CPR with a shockable rhythm. How many doses of epi would you give before giving them amiodarone? So that doesn't matter. What it's going to be more in relation to is going to be giving it if your defibrillation is not working, right? So if you shock them 3 or 4 times and that's not working, then you could switch over to using amiodarone. So instead of using electrical cardioversion, you're trying to do a chemical cardioversion basically. The epi is just going to be given consistently regardless of whatever else you're giving, because honestly, like a lot of data is, honestly, the outcomes are really poor if you have a patient who's in cardiac arrest. And really, epi is the only thing that's shown like really good consistent benefits in terms of having a return to spontaneous circulation and things like that. So that's just going to be given regardless. So it's not really like you give epi and then amio, like you're giving amio and epi at that point. So that makes sense. If not, let me know. Let's see. All right. So as I mentioned, how do you pick an agent? I'm sure you guys are wondering that already. Consider the patient condition. So if they have poor cardiac output, but their systemic vascular resistance seems to be okay, you could use something like dobutamine, isoproterenol, milrinone, that intermediate dose dopamine, totally fine there. If they have cardiac output and diminished systemic vascular resistance, that's where you want something that's going to be kind of working on both sides of the equation. Using high dose dopamine is good there. Norepi, epi would be fine as well. If they have diminished systemic vascular resistance, but their cardiac output's okay, then usually you'd probably go with like Norepi in a lot of those cases, or you maybe add on like phenylephrine potentially, right? As I mentioned, septic patients, they are going to be more likely to require things like vasopressin to help as an add-on to help get their blood pressure under control, just because they are third spacing like a lot of fluids, and the vasopressin kind of helps to prevent that, kind of keep the water in the vessels themselves instead of it getting out to the tissues. So as an example, when I had a patient who had overdosed on minoxidil, so it was a guy who's a chronic alcoholic, and he had lost access to, I don't know if he did have funds to purchase alcohol, but he was found basically unconscious in a Walgreens because he saw that the Rogaine, the minoxidil, had, I don't remember what the concentration of alcohol was in it, but it was fairly high. So he decided to drink that in order to, prevent withdrawals or whatever. And then basically came in profoundly hypotensive, and we had to utilize like 4 different vasopressors just to get his blood pressure, just to get his MAP anywhere near normal. So I think he's at one point was on Norepi, Epi, Phenylephrine, and I don't know if we tried vasopressin or not. This was a while ago, but he was on between 3 and 4 vasopressors all at the same time just to get his blood pressure up, and it was pretty difficult since minoxidil being a direct vasodilator, it was really kind of fighting us pretty hard on that one. He ended up doing okay. Yeah, it was pretty wild couple of days for that patient there. Anyway, so let's go over a few miscellaneous topics here. So first off, we have hyperkalemia. So potassium, as you know, I always like to use the analogy that our cells are salt-wrapped bananas. I say that because we have a high extracellular sodium content, but we have a high intracellular potassium content. So about 98% of your potassium should be inside the cells in most times. And again, when you're looking at, for instance, like daily requirements of sodium and potassium, they're almost identical, right? So like when we're dosing this for total parenteral nutrition, so IV nutrition, if you look at the actual amounts of potassium and sodium we're giving for to start out, they're generally the same. It's between 1 to 2 milliequivalents per kilo. And the reason why you're giving so much potassium, even though if you look at the blood levels, 3.5 to 5 versus 135 for sodium, is because all of that potassium is inside of the cells. So that's where all that potassium goes. And so it helps us out with things like regulating the excitability of our neurons and our heart. And specifically, we're going to focus on the heart effects here, since this can be pretty fatal in either direction, either hypo or hyper. But hyper certainly is something you're probably going to see more commonly. And again, we have a pretty narrow range that we keep this in, between 3.5 to 5 milliequivalents per liter. And again, the kidneys are going to be the main thing that's going to be excreting these. So if you have someone, for instance, who has chronic kidney disease, is on dialysis Monday, Wednesday, Friday, but they missed their Friday session, they might be coming into the ER on Sunday with their potassium like 7, and getting palpitations and whatnot, right? Not a too uncommon scenario you might run into. So other reasons why you may run into hyperkalemia includes they have increased intake. So if perhaps they were consuming large amounts of bananas, perhaps. I'm just kidding. It'd take a whole lot of bananas in order to get hyperkalemic from that. There's about, I think, 1 milliequivalent per square inch of banana, I think, is the average. So yeah, interesting tidbit there. Or if you have things like ACE inhibitors, NSAIDs that are directly affecting the kidneys, especially ACE inhibitors and ARBs, they're blocking aldosterone. So that can certainly lead to higher potassium levels, especially in those that have concomitant renal dysfunction as well, right? So again, you're going to see mainly cardiac effects from this. So you're going to see things like peak T waves, wide QRS, that can lead to VFib, asystole. Not great, right? Neuromuscularly, you can see some things like paresthesias and weakness, since you are affecting the ability for those neurons to really kind of reset back to their resting membrane potential, since you have such a high extracellular content that's affecting that. So how do we treat hyperkalemia? I like this mnemonic, and I got validation for this from some of my students who do their ER rotations, and their preceptors would pimp them on how to treat hyperkalemia, and they said this thing saved their butts. And so I said, all right, I'm going to keep teaching it then. It's see a big K drop. So look, see a big K drop. That's how I remember the medications to use here. Now, this is not in a particular order. I'll talk about when to use what, but this is just the list of things that you can use, okay? So you can give calcium. We're giving albuterol. We're giving bicarb, so sodium bicarb. There's insulin and glucose that we'll be giving. KXL8, which is a brand name for a drug I'll talk about in a moment here. And then dialysis. Dialysis is probably like the ultimate thing you can do, but may not be the easiest thing to do there. So that's the mnemonic I use to remember all the things. Now, not all of these are going to do necessarily a whole lot to the potassium level or be able to get rid of potassium, but we'll look at the different options and what they can do for us. So first off, calcium stabilizes the myocardium, right? It helps to reduce that threshold for the electric potential, so that way the myocytes can get back to their resting membrane potential more easily, and it helps to kind of prevent that potassium from aggravating it too much and stabilizes that membrane, right? Love the mnemonics, yep. Although who put an M in front of mnemonics, right? Like that's kind of mean for people who have a hard time spelling. So this is beneficial even if you have a patient who has normal calcium levels. You can still give calcium on top, and you should, right? This will help you out for about 30 to 60 minutes until you can kind of get more definitive therapy on board, right? So whether it is dialysis or something else. And then generally, if I have a patient like this, unless they're like coding, you can give calcium gluconate. So probably going to give, between 2 and 3 grams. And you can remember that 3-to-1 ratio of gluconate to chloride, right? So things we can do to try to shift the potassium into the cells, okay? So if it's, the issue is that we're having too much potassium on the outside of the cells, we can try to shift it in to give us sort of a temporary relief, okay? Now, it doesn't get rid of the potassium. It's still there just sitting in the cells and eventually it can come back out, but these are things that we can do to try to shift it in and give us some breathing room, so to speak. So first off, speaking of breathing room, we have albuterol, or we could actually use terbutaline. If you remember, we talked about that back in the OB-GYN section. We use it as a tocolytic to relax uterine smooth muscle. Here, the albuterol is useful if you have a patient who doesn't have IV access yet. Otherwise, I would go with the terbutaline if you do have easy IV access. And usually you can use this as like a continuous nebulization there. Not, you don't cam it, but you can use a continuous nebulization there. Most common side effects due to the beta-2 activation on the skeletal muscles, you can see tremor, you can see tachycardia most frequently, right? Patients feel kind of jittery when they're receiving this. However, if they're on a beta blocker, because maybe they have, previous MI, kidney disease, and they're on a beta blocker, and then kidney disease led to the hyperkalemia, they may be more resistant to that, right? Because the beta receptors are being occupied, that may be a bit of a problem there. So one thing to note. And we also do bicarb, and this is going to be really beneficial if your patient's acidotic. Typically, you're going to find when patients become acidotic, their potassium has a tendency to shift outside of the cell. And you'll see this too a lot, like in, for instance, with DKA, a patient who's in diabetic ketoacidosis. They're kind of interesting because they will get really acidotic. Like you can see them like down in the 6.8, 6.9 pH range. And so they'll have all this potassium shift out, but because they're so hyperglycemic, they also get this diuretic effect. And so they end up peeing out a lot of their potassium. So they've shifted it out of the cells, but they're also getting rid of it more quickly. So when you look at their potassium, they look normal, even though body-wide they're actually depleted. So it's really important to give those DKA patients back potassium in their fluids, as a side note. But in this case here, if your patient is hyperkalemic and acidotic, then we can give sodium bicarb to try to shift that back in. And so that can be very beneficial from that standpoint. And again, you're normally targeting like a normal serum pH, so 7.35, 7.45. If we're doing it for tox stuff, normally we'll go a little bit higher than that. So normally we'll go like 7.45 to 7.55 is kind of what we're shooting there. It's pretty narrow changes, but even small changes like that can make a big difference in terms of your pH, right? So we're trying to keep things basic, try to increase their pH. Yeah. Anyway, so other things we can do to shift potassium into the cells includes insulin and glucose. This basically helps to sort of put the sodium potassium pump in the sort of high gear because it's in sort of a bigger metabolic state because you're shifting all this glucose into the cells here. And so this is where, again, you always in this situation have to give insulin plus glucose. You don't want to give insulin by itself because then you could bottom out your patient's sugar and then you have a whole new problem to deal with. So we will give 10 units of regular insulin, nothing else, just regular insulin, in addition to 25 grams of dextrose. Sometimes you may need a dextrose infusion if they're particularly sensitive to the insulin, but otherwise that will again help to shift the potassium into the cell. Okay. And again, so far we haven't seen anything that gets rid of it yet. In order to eliminate it, we could do things like diuretics, but we don't necessarily get the most predictable benefit from that. And if anything, it can cause them to become dehydrated and cause sodium issues there. So, if they're fluid overloaded and hyperkalemic, sure, yeah, loop diuretic is probably not a bad idea there. But other ways we can try to get rid of it is by giving an exchange resin. So this is a product called sodium polystyrene sulfonate, or SPS, or KXLate. This is how it's commonly known. And so basically this is a resin, called a cation exchange resin. So basically this resin has a bunch of sodium on it, and it can swap it for potassium. And this is normally either given orally, or if the patient couldn't tolerate anything orally due to, depressed mental status or whatever, you can do this rectally even. So place this into the colon, it'll start to swap out potassium for sodium, and then they can then eliminate it through the feces. And that is one way. It's not a fast way, but it's one way to try to get rid of some of that potassium. Constipation is pretty common with that drug anyway. The other way to ultimately get rid of that potassium is with dialysis. Obviously, this would be ideal if a patient was like a known dialysis patient and they had a fistula or something. And this can help out with just an hour or two of dialysis. You can drop their potassium by 1 to 2 milliequivalents per liter. So very effective at what it does in getting rid of that. So again, only two things here that really get rid of the potassium. Everything else is either to help stabilize the myocardium or shift the potassium into the cells to give your body some time to kind of recuperate and get rid of it maybe through the urine there. Someone's asking, did I say phenylephrine can cause renal hyperperfusion or hypoperfusion? I know I speak a little quick, and hyper and hypo can sort of get mixed up there. Phenylephrine, as a vasoconstrictor, can cause hypoperfusion of the kidneys. Okay, the only thing that really increased kidney blood flow that we saw was that low dose dopamine. Everything else, though, that's going to be acting as a vasoconstrictor can decrease perfusion to the kidneys, leading to kidney injury. Right. That's why it's so common that we end up seeing, like, especially septic patients who are hypotensive, when they're on vasopressors. It's pretty well known in a lot of cases they can develop kidney injury secondarily to that because of what we're doing, basically. So not ideal. Some said, this seems like a lot of medications to give at once. At what level of hyperkalemia would we proceed with this large regimen? So it's not that you're given everything at once. Some of this stuff is being done sequentially. Some of this is being done in certain situations. So for example, if I have someone who has IV access, I don't need to give them inhaled albuterol, right? I could do IV terbutaline. That would be totally fine there. Again, how symptomatic is the patient? How likely do we think, are they having EKG changes that we're seeing that could make us think that this is more serious? How elevated is the potassium? All could be ideas in terms of like how you decide what to give and when to give it. And again, if the patient's acidotic, we'll give them the bicarb first. That makes more sense because that'll help to correct that, right? They may be hyperkalemic because of the acidosis. In the other situations, we might pick one over the other. Again, K-Xylate does not generally, it's tough to do because it's kind of slow, so that should be one of the last things you're probably going to get on board. But in the immediate, like, give it to them right now. Like, calcium is going to be a big one. Insulin and glucose and the bicarb. Those are probably the three big ones that I see given, like, kind of knee-jerk as like the first line agents. Then if you think about it, we'll get the terbutaline on board. We may start to think about getting the K-Xylate on board as well. Then the ICU people are down, they're going to set up and we can admit them. So that's kind of the process there. But I wouldn't ask you necessarily, if I'm asking questions on this stuff, I may ask more questions such as, let's see here. Like, not necessarily like, when to give one versus another, but like, what do they do? Like, which one of these actually gets rid of potassium? Which one of these helps to shift it inside of the cell? Which one of these might be, contraindicated for whatever reason, things like that. So those would be more the things I'm going to focus on from that standpoint. So nice to tell you all the test questions ahead of time. Right, everyone doesn't make 100, right? Okay, so just to finish up, just to kind of recap, just because we're talking about, all things ER here. Anaphylaxis treatment, and we covered this back in pulmonology, but I like just to touch on this again, just to, look at this, I have ranitidine on here again. I keep forgetting to update that. Famotidine. So typically when you're thinking anaphylaxis, and again, this is similar to hyperkalemia, it's all a question like, do you give all the meds at the same time? Or do you give all of them at all, like, or are you going to be more selective? Again, it depends on the situation, how symptomatic the patient is. If I have someone who comes in with anaphylaxis who is like full blown grabbing their throat, they can't breathe, like, yeah, they're going to get the full court press, versus they come in with some rash after being exposed to a peanut or something, like, then that's going to be a very different picture there, which might dictate which meds we're going to be giving, right? So first off, most patients are going to be getting antihistamines during this, right? Not everyone may get an H2 antagonist. Certainly if they're having GI symptoms related to this, I would certainly consider giving something like, an H2 blocker, like famotidine, for instance. But antihistamines, first-gen antihistamines are generally speaking going to be recommended for most patients with some kind of allergic response. Whether it be diphenhydramine, chlorpheniramine, hydroxyzine, any of these are totally fine. Obviously, the more sick the patient is, the more likely we are to do IV versus oral. So that's one thing to consider there. For some patients, chronically, they may get some benefit from using something like cetirizine, which is Zyrtec. But usually in the hospital setting, we'll do diphenhydramine probably 10 times out of 10 in terms of H1 blockers. Corticosteroids are also going to be used for the majority of these patients as well, maybe as short as like a 5-day course of prednisone or something, but just recall they do take some time to kick in because they have to get down to the nucleus and change gene transcription and all that kind of stuff. This is not going to be the thing that's going to correct the patient like right that moment. Okay, still want to be expedient about getting it on board, but it's not going to be the fastest thing. So methylprednisolone, hydrocortisone, those are typically IV products you're going to see being given most frequently for anaphylaxis. Prednisone and prednisolone, pretty common orally used ones we'll see there, especially if they're going to go home afterwards, right? And then epinephrine is generally going to be used intramuscularly for any patients having like really severe reactions, that they're becoming hypotensive, if they are having any kind of like airway edema. This is when epinephrine is most definitely going to be used, right? So this is the drug that is kind of most variable in terms of who's going to get it or not. Most of the patients with any kind of allergic reaction is going to get some Benadryl and probably some corticosteroids. Not everyone's going to get epi. This is really going to be for the more symptomatic patients that are hypotensive or having airway compromise. And so IV we only do unless the patient is like really hypotensive. IM is totally fine in most cases there. And sometimes we even need continuous infusions. They can have such severe reactions that we need to do that just from the airway management sort of standpoint there. But yeah, so just remember when to administer that. All right, so that's it for the ER section. You guys have any questions about that? So what is today? Today is 4/8, so that means I got 4 more lectures to do. I got 2 more sections. So what I think I'm going to do, because it is Friday afternoon, unless I see an overwhelming response from you all that you would like me to continue, I'm going to go ahead and cut it off there for today. And we'll do the immunization section next time we meet, which will be, when do we meet next? Tuesday. So I think we have a Tuesday, Wednesday, and then we meet the following. So we only meet 2 times next week. So we're going to go ahead and I'll do the immunizations. We'll do toxicology, and that'll be the last couple sections. And then we'll have our review at the very last section. I know some people get mad. They're like, "Why are you? We're paying for this. Why in the heck are you not using it the whole time?" But I think it's okay to have some trying to think for the word, some grace every once in a while. Anyway, so someone says, if corticosteroids take time to work, why is it given during emergency crisis like thyroid storm? Again, you still, may want to give it, it does take some time to work, but, again, it's one of those things where, like, if I had to make a decision between giving someone epinephrine or the corticosteroid, I'm probably going to go with the epinephrine first in the case of anaphylaxis there. But, so you're still giving these things during the emergent situation. It's just a matter of like looking at your priorities of what you want to get on board right this second. And the epi is usually the first thing. But I'll have cases where like, the nurse is calling me or I'm not there in the ER and the nurse will be like, "Where's the corticosteroid? We got to get the steroids." And I'm just like, I got to get the epi first. Let's get that first. And then, because the patient, can't breathe, so we don't intubate them, hopefully. And so let's do that first, and then we'll worry about the corticosteroids. Sometimes you got to kind of, put things into perspective for people if they just don't know, Yeah, leave them one more. I hope so. Yeah. Everyone deserves a break, right? This is my 4th lecture for you guys this week and my 6th overall. So it's been quite a busy week. So I'm going to give my vocal cords a rest. Thank you all for joining me. I hope you have a great weekend. I'm going to be doing daddy daycare. My wife is working this weekend, so it'll be fun times overall. And yeah, I'll see you guys next Tuesday. Have a good one.